afternoon, everyone. My name is Darlene Batting. I'm the Director of Long-Term Care, and I've had the privilege of leading RPIW number 333 for the meeting. We will be speaking to a TAC time of 20 minutes. So I would just like to show you the picture of our team, and it's an awesome team, and we decided to go with actually our patient rep chose the name 336D to go along with Chris Zarka of the Riders that I spoke about on Monday. I know I said the jersey was to come and my husband didn't come through with that, so sorry about that, but our sponsor Carol wore green, so thank you, Carol. Did all the work, so I'm going to ask Annalie and the team to present what our findings were, and I will close. Thank you.
She is always a hard act to follow. Great lead we've had. My name is Annalie Stuckel. I am a registered nurse. I work for home care, and I'm the sub-team lead for RPIW number 33. Our target statement is that our focus and our purpose was to increase the number of level 6 patients with an achievable predicted discharge date. Our sponsor was Carol Gregorick in green, and our process owner was Sharon Griffin. A couple of things off the project form that I just want to mention about the current situation that we found was that we were finding that there was the grounds for discharge planning were occurring but did not occur with patient input, that we had a D system indicator but it was not fully understood, and that there was really no definition for confirmed or predicted discharge dates. Current value stream map. You'll see that we again had some trouble trying to figure out what our focus of our workshop would be. We did sort of arrive at the fact that we would start a process with ACAP identifying in an assessment that there was a patient to do some discharge planning around. It took 6 steps to actually get the patient identified ready for discharge by the team. So you can also see that we had many starters in our current value stream map. The lead time in our current state was 91 hours and 36 minutes. Our cycle time was 1 hour and 37 minutes. So you can see that we ended up with some non-value added time to the discharge process of our patient during their stay at about 98%, with 2% value added to the discharge process. Looking at our target progress report pre-Kaizen, the RPIW, certainly when you see all the defects in the process, became more about the defects and less about the flow. And we just noted that in our defects we had PSAG boards that weren't being updated. Actually they weren't updated daily for 6 days in a row. That multidisciplinary rounds were only happening two times a week, so 5 out of 7 days there was no discussion around discharge planning by the team. And that we had an ACAP process that's valuable to definitely to the work that they're doing, but we noted that there was actually causing some delays in starting the discharge planning conversations on the floor. We also have a lot of inventory in our 5S area, and of course a lot of space occupied by that inventory. So focusing on multidisciplinary rounds and the TAC time around discharge discussions, we determined through our TAC time that about 6 minutes a day per patient was spent on discharge planning discussions. And looking at our rotor wheel or our waste, during our waste walk, you can see again that we were able to identify a lot of areas where there was waste occurring, mostly in areas of processing, time on hand, and overproduction. So you can also see in our post-Kaizen on our waste wheel that we were able to make several changes, and our post-waste walk demonstrates these improvements. And I'll introduce Debbie.
Hi, my name is Debbie Wendy. I'm the nurse manager on level 6 and a participant for this RPIW. I'm going to speak to some of our timed observations pre and post Kaizen, specifically to the process to identify the patient for discharge. So pre-Kaizen we had a time of 90 hours from the patient being identified to be seen by ACAP, reviewed in multidisciplinary rounds, assigned a targeted or tentative date of discharge, and then being identified for some discharge planning. Our team worked really hard on a lot of idea sheets and included a couple of PDSAs so so that we could move forward with some decision making, some subsequent development of standard work and some work standards in regards to updating the PSEC boards and implementing a number of other new processes on the floor that my other teammates will speak to. Our steps have been streamlined to identify the patient for discharge planning. We have implemented daily bedside rounding, which is a face-to-face review with the patient alongside with the nurse manager or their designate and the PCC on the floor. Multidisciplinary rounds will remain as twice weekly, but those daily rounds that are happening Monday to Friday with the patient input is going to provide us with much better current and relevant information that's going to help us move forward with discharge planning. So our wait time has decreased from just over 91 hours to just over 57 hours. So that gives us right now a 37% reduction in the time to discharge planning. The next thing I'm going to speak to is a spaghetti diagram that was used to measure prep for multidisciplinary rounds. Now this was done in my absence, so that was having one of the nurses on the floor who's not generally accustomed to doing rounds on a regular basis, so probably a little bit more prep time, but that it showed a prep time of roughly 6 minutes. So we've made some changes here as well. With our multidisciplinary rounds, we are eliminating the use of the binder with paper forms with information because we were finding that other than getting written in once a week, it really wasn't getting utilized to anybody's advantage. Also developed some standard work where the PCC is going to be responsible for bringing our patient status at a glance board to these multidisciplinary rounds. That will evolve through to our workstations on wheels once we move forward with SCM. So it brings the pre-Kaizen timing of 6 minutes down to post of 16 seconds.
Hi, my name is Dr. Harris. I'm a family physician, and I work in the community plus at Victoria Hospital. A couple of things that I'm going to speak to in particular. One was the fact that the D system for discharges really wasn't understood by me. It wasn't understood by most physicians, as well as many of the staff members. So one of the things that we did was to try and educate people was to do a small card like this, which is now taped on the inside of each binder chart on level 6, so that the D system key is there for anyone to look at any time, be in your face all the time. Part of that, another part of it was that I made a commitment that I would go and do some education, I think along with Sharon, at a physician meeting, just so they become accustomed to the D system for discharge. The second part was the problem was identified that multidisciplinary rounds on level 6 were falling a bit by the wayside, especially when the nursing unit manager was away. So we did work on developing a work standard and a script for a nurse who might not be familiar with how to carry it out. So we trialed it, and I was the nurse who chaired the multidisciplinary rounds, and it turned out fine. I worked from the script, and we did it in less time, and it really worked well. So as someone coming in totally not knowing anything, we were able to do it with the aid of that script. So just being involved in this process, it's a complicated thing, and the best that I could figure out is what with JVA and KPO, Team 3360's RPIW was about patients from ER and ICU coming to level 6. ACAP using Chi-High set to the LOS, then RNs, LPNs, and U of S students plus the MD, the FMR1 or the FMR2, and the Jersey Begin Care. At the MDR, the NUM, or the MSC, from the PCC, OT, OTA, SLP, PT, PTA, especially if there are TLRs, and EG, COPD, RT, if patient is a homo too. So the PCC and the NUM or the MIC use the MDR to revise ACAP's Chi-High ELOS on the PSAG to an achievable TDD or EDD using the D system compatible with SCM. So that's quite an academic soup, but it actually prompted our patient team member to come up with a really great idea based on that kind of concept. And before I stop, I just want to thank all my team members for making me LOL.
Pretty tough act to follow, I know. My name's Audrey Swak, and I was the patient and family rep on this team. Part of what we came up with as an idea was something to sort out all of that alphabet soup. Something that could be at the bedside to help families and patients understand what all of those many caregivers might be expecting, what their roles would be. This is just more of the idea. So this is what we did. We developed the sheet, it's laminated, and it's kept at the bedside. And it was developed to explain in really simple language the terms for the roles of various members of the care team. Mark Beeson and I also were responsible for the 5S project. And it was to organize the cupboards behind the level 6 nurses station. Everything was removed from the top shelves, or the top of the cupboards, because you can't see up there anyway. There's nothing there now. Old texts and reference books were taken to the library for the Take for Free shelf. The remaining books were stacked so that all the titles were visible at a glance. Duplicate binders were removed, and the remaining binders are organized according to topic, and their spot is labeled on the shelf. Anything that was not necessary was removed from the counter and placed where it belongs, freeing up some badly needed empty space on the counter. Drawers 1 and 2 were decluttered, organized, and labeled. Small items are now in baskets. Electrical equipment and the headphones were taken out from under the sink and put into baskets on an appropriate shelf. Patient belongings were removed from the floor, and numerous items were moved to where they belong on level 6. That's one whole cupboard is now empty, as well as the users. More than 2,000 items were removed, and our 5S evaluation improved from 1.2 to 3. Thank you.
Hi, I'm Barb Thiessen. I'm an RN on level 6. I was a participant for this RPIW. We have created work standards and standard work around the MDR, huddles, and PSAG board. Education has begun, and so far this week we've reached 25 nursing or physio staff and 1 doctor as well. We've received a lot of positive input and interest, and appreciative feedback was received. We're using a multi-skills training sheet to document education received, and we're looking for 100% of staff and doctors being educated. I created an RPIW process binder that will be left on the staff table for casual perusal. Education is going to be ongoing. Jamie Lynn.
Hi, I'm Jamie Lynn Jazowski, and I am a patient care coordinator in level 6, but currently I'm in intern home care. So our RPIW team created standard work and work standards to implement a daily bedside round on level 6. So each room was given a whiteboard which lists the patient's name, the date, the nurse for the shift, the patient care coordinator assigned to them, their estimated date of discharge, and any patient, family questions or concerns. The nursing unit manager or the nurse in charge and the patient care coordinator are meeting daily to complete the bedside rounds with the patient. During the rounds, the PCC updates the bedside board and notes any concerns for later follow-up and case management. At that time, the estimated discharge date is communicated to the patient if it is known. The PCC then will update the patient's status at a glance board to reflect the same discharge date as the patient's bedside board, and also identify any barriers to the discharge. So this process will significantly decrease the amount of time between when a patient is assigned a PCC and when the patient actually gets to meet their PCC. And we anticipate this process will assist the PCC in prioritizing their caseload and identifying those discharge barriers earlier on. The daily PSEG board update will ensure the patient's TDD is accurate and achievable. So teaching began with the PCC this morning. It'll have to be ongoing, especially since there's going to be some new hires. But most importantly, the most important outcome here though is the improved communication between the patients and their care team.
Hi, I'm Brandy Cook. I'm a fourth year nursing student doing my final practicum on level 6. So during our initial assessment, as Dr. Harris had stated before, there was problems with understanding this patient at a glance, or the PSEG board. So we came up and developed this colored legend to help people better understand the information that's on it. We posted one in the education binder, as well as had one printed and laminated and placed right above where the PSEG boards go. Also, in regards to the information, a work standard was created for the D information and how to enter it into the system. So this work standard can be used for any team member that will be utilizing it, whether it's on the PSEG board or in the future the Sunrise Clinical Manager. And just to help with the audits, a tally checklist was developed just to aid in the 30, 60, and 90-day audits in regards to the newly initiated daily bedside rounds, updating the PSEG board, and also the multidisciplinary rounds.
So, following all of that, to summarize the work of the team, our final target progress report, a lot of the changes were already identified, but the defects went from 6 on the PSEG board to 0, which was 100% improvement, as well as the multidisciplinary rounds only occurring twice a week to actually 5 days out of 7. So again, a huge improvement. We were able to also improve our productivity and capacity because our patients were being seen sooner and discharge planning was happening a little quicker. So the difference in our value stream map, as we talked about, we really struggled with what process we were actually looking at. There have already been several RPIWs on discharge planning. We really were putting our heads together to see what the issue actually was and why the process was not so successful in other units. So we actually narrowed the process down to pull up pieces in the waits that were identifying long periods of waits with wait for people to be seen by ACAT. So that process is still very necessary, but we're actually moving it to a different flow because it didn't reflect what we were looking at. We're trying to put the right people in the right place at the right time. So we were able to improve our lead time and our cycle time as well as our productivity. So our newspaper, we have several items in, or a few items that we need to keep working on. Of course, communication is huge because we did implement a lot of education on standard work, the PSEG board, the D system, so that will have to be ongoing. So Debbie and her staff will have to look forward to all of that work. So in workshop summary, I think we mentioned several of them already. Probably the most significant one is moving the discharge planning right to the patient bedside and starting it earlier on in the process. We developed lots of work standards and standard work with them being able to be transitioned straight into Sunrise Clinical Manager and then real-time bedtime capacity. The one thing that's not on there that I think probably should be is that we didn't develop any new forms. We just looked at using what was already in place. We stole shamelessly from other areas and tried to just use them a little bit differently and more efficiently. And the diversity of the team members was truly beneficial to this RPIW once we worked through the kinks and struggles of trying to decide what we really could do in such a short period of time to improve this process. So lots of thank yous again to our KPO, Deb, and Carol, our sponsor, and Sharon Griffin, process owner, who did lots of running for us for this and that and everything else. Brad from the print shop, level 6 staff that were awesome. We were intruding on their staff room a lot, and they were just great. And they were actually very engaged in the process. But the most significant thing I would like to thank, or group I would like to thank, is my team. We were so fortunate we had Anna Lee from her home care background, who was very educated on the D system. Having a physician, very engaged right from the start. Patient rep, our student. We had so many pairs of eyes seeing things for the first time and giving it a totally different perspective. Myself from long-term care, it was very, very rewarding to be working with such an incredible team. It's easy to be a team lead when you've got such an awesome group to work with. So you want to talk about better teams? I couldn't have had a better one. Thank you.